patient no longer needs a caregiver, if they don't have those needs, this can also show progress. So if you're looking at ADL assist, IADL assist, medication administration. And by the way, looking at this and comparing it to the functional moves, any of the 1800 M items, you can actually see consistency and congruency in your assessment.
So that last column is there for those people that you said need assistance, but they don't have, they're those people that live alone and refuse to have anyone in the house.
Right.
Those are all your number 4s over on that side.
Yeah.
It's not what are they doing, it's
APS.
Well, that's a good time to think about that. MSW at least.
right.
The least you should think about is an MSW, and we don't want to call APS unless we really need to on a patient. But if it's indicated, we will,
Right.
because we are mandated. Okay. 2300, wording change to include timing since the previous OASIS assessment. These are the ones regarding emergent care and hospitalization and those things. In 2310 was the reason for emergent care. They included adverse drug reactions and wording specificity. Again, 2400, which is about hospitalization, the timing is to include since the previous OASIS assessment. And skip patterns updated in 2410 and 2430. So that's where they are. You see emergent care, reason for emergent care. So it now says at the time of or at any time since the previous OASIS assessment. So the timing they're doing from OASIS assessment to OASIS assessment. One of the other things that you'll see in the OASIS that they've done for the OASIS C1, instead of using abbreviations, they have spelled out the words. So instead of E period G colon, they actually are writing the word example.
And you might note too that UR is finding, you know how we check all that apply.
Right.
Okay. Patients had a fall, they weren't injured, but they were re-hospitalized for UTI. If you're checking injury caused by a fall, that affects us outcome. That is incorrect. They're not hospitalized because they fell. They did fall, but the hospitalization was due to the UTI.
But they fell because of the UTI and there was no injury.
Right.
So the real reason they were hospitalized was because of the UTI.
Right.
And in 2400, it's the same.
One thing I want to say about the depression that's different on the OASIS C1 is if your patient is showing signs and symptoms of depression, we are allowed to open the problems without the diagnosis and create a care plan for that, but you must notify the MD they're showing, and obviously get a social worker. But those two should go in hand. You're going to notify the MD they're showing signs and symptoms of depression. This happens a lot with new diagnoses. I've seen many CABG patients that are tearful when they're talking to me because of the loss of control of their life. This is a period of depression, and we've always taught you've got to have that diagnosis or you can't have a care plan item. This is now the exception to that. They have allowed them not to have the diagnosis for depression, but to show that on your care plan that we're monitoring it. We'll let the doctor know, look, they've had, they're having a down period in their life. We're going to monitor for signs and symptoms. And then we're going to close out the problem when they start to recover. Or if it gets worse, we'll notify and say, we recommend medication or something further. You'll get an MSW. But I want you guys to know, going forward with this assessment, we must address their depression-like symptoms, okay?
Yeah. Newly diagnosed cancer patient, you know they're going to be depressed. Who's going to be happy about that? So, that's a period of time that they're depressed. And
when they're dealing with things.
Yeah.
or someone having to go into assisted living, and then, you know, because they had a fall or whatever, now we're out there, and they go, you guys know exactly the patients that when you ask them about how they're doing, they can't finish their conversation without you, without getting tearful. We have to address those issues, we have to notify the MD, and we should be sending a social worker out.
The other piece with the 2400 and the discharge is that if you did not identify any of these items at the start of care because the patient wasn't exhibiting them, or they didn't have any, or they didn't seem to be at risk for any of them, so that you checked NA, but during the course of care, it came up, you would want to put that in here. Because it says, if you read it, it says, at the time of, or at any time since the previous OASIS assessment, were the following interventions both included in the plan of care and the physician or parent plan of care, which includes any of your verbal orders or your supplemental orders, and implemented.
So the only time you'd have a no on this is if we did fall preventions and we didn't address it. We opened the care plan, but we didn't do anything about it. You would hit a no.
Right.
If you opened the care plan and you told them to remove their rugs and they still didn't do it, you addressed it, so it would be a yes. You have to have those problems. The problems equal the yes. The zero problem is the not applicable. If they had diabetes, but no one ever during that cert period opened diabetic, then you would hit not applicable, even if they had a diagnosis, because we didn't address it, which is not likely. But if they had pain, but no one ever opened a care plan, guess what you get to answer? Not applicable. So you really have to go to all your problems, your active and inactive, especially if you're discharging somebody else's patient. You need to go back to that start of care date and see if any of those problems were resolved, because they want you to go all the way back and make sure, okay?
And they went to the ocean because